for that, because we have members now that would have completed other committees that would be available to us. We haven't established a quorum yet. We had initially planned, we've got a series of roughly 10 bills. My mind's in a fog right at the moment, but we've got 10 bills in front of us today that we're going to have to take up at some point once we establish a quorum. But we also, this being our third meeting, we're still hearing, getting some budget briefings. And one of the important briefings we intend to have today is from Dr. Colin Green from the Health Commissioner. And if you would come forward now, we'll just go ahead and do that briefing right now while we still are awaiting a quorum and while we have members coming. So thank you for making time to be with us here this afternoon. Yeah, there, you can go right there. That will be great. Thank you.
And just press that.
Oh. All right. Well, I'd normally say Mr. Chairman first, but I guess Mr. Chairman isn't here.
Well, we are the chairs.
You
here
are the
today.
chair.
Right. He and I are co-chairs, and I'm
Madam
running the
Chair,
meeting today, so
Senator.
you can look this way.
All righty.
This is it is right.
So I'd like to offer a presentation to this committee of the line items from the governor's budget proposal that are pertinent to the Department of Health. And you all will you be looking at slides or will you be looking at the screen? Either way, I'll work
Okay.
them both. So what we do, the Health Department's mission is to protect the health and promote the well-being of all people in Virginia. And there's three parts to that. So we protect health, so we try and keep disease away from people. We promote well-being. We encourage healthy activities. And then the all people in Virginia line is our commitment to equity. Our vision is that Virginia becomes the healthiest state in the nation. And that's something we'll always keep at. Strategic goals. People are our most valuable asset. That's goal one, is our workforce. We want to be connected to communities and help them to be resilient. We want to be a trusted source of information. We want to ensure the conditions that improve health opportunity, again, for all Virginians in all locations. And we want to provide internal systems that deliver that constant and responsive support. This chart shows appropriations for FY 2023 and expected or predicted appropriations for FY 2024. There are a few large muscle movements. The most notable one is the yellow section at the bottom shrinks. That's the federal COVID funds. We expect them to decrease. We'll expect them to decrease substantially more, pretty close to disappear probably in FY 25. The federal, and then some of the other sections have gotten larger just because the denominator has gotten smaller, but the federal section at the top left has grown by not quite $80 million, and that is from the national bipartisan infrastructure law, which makes money available to our drinking water state revolving fund, which I'll talk about as one of our line items. The growth on the top right in the general fund will be most of the rest of the requests from the governor's budget, and then the slight growth in the special section, about $6 million, will come from a request from use of opioid funds. Most of the larger line items in the governor's budget proposal address two extremely large problems we have in Virginia, and they reflect the same issues nationwide. The first one is a shortage of access to mental health care. Again, it's a nationwide problem, but 41% of Virginians live in what's referred to nationally as a mental health professional shortage area where there's just not enough providers. That's larger in Virginia than nationwide. Nationwide is only 30%. And then of our 133 counties and independent cities here, 26% of those have either no psychiatrist or psych nurse practitioner. In other words, no mental health professional that's able to prescribe. And another 19% have only one prescriber, so that's 45% either have no prescriber or they have only one. Many of these prescribers are near retirement age as well, so they're kind of on the edge of a cliff as far as staffing. There are some national efforts underway to increase the number of psychiatry residencies. That is expected to have some success. However, it's going to take time. A residency is 4 years long. You have to convince a medical student to go into psychiatry, so we probably won't see any results from that 6, 7, 8 years, maybe longer. And psychiatry is among the lowest paid medical specialties. So you'll see two of our programs that'll be proposed here shortly that are intended to help that issue. The second one, again, part of a larger national problem, is a nursing workforce shortage. So in Virginia, pardon me, we have somewhere in the neighborhood of 60,000 to 70,000 registered nurses, and about 6,000 of those positions, permanent positions, are vacant. Nationwide, the problem is again broader. A couple of things. One is there are about 3.1 million registered nurses nationally. The average age of a registered nurse working in the United States is 52 years old. So a substantial number of them are expected, in fact up to 1 million in the next 7 years are expected either to retire or leave service. And during COVID, we actually saw a fair number of nurses in their 30s. So younger nurses also decide to leave. This shortage of nursing workforce is most acute at the state mental hospitals, so psychiatric nurses. So again, these two shortages have a crossover here. 40% vacancy rate, so it's impossible to fill up the hospital and give quality care. The rate limiting factor for patients is not beds, it's not building size, it's nursing staff. And then one of the biggest problems in producing training and graduating new nurses is clinical training. So there's 2 years of kind of book learning in a Bachelor Science for Nursing degree, and then there's the 2 years of clinical. The book learning is more flexible. A lot of times people can even do that in night school, but the clinical aspect, you've got to be out on the ward, you've got to be in the clinic, and you have to have a preceptor to train you, and we'll talk about that in a bit too. And then finally is the cost of education itself and the necessity for someone who's probably already employed to have to leave their work to go to school and do their clinical training, and we'll address that. So 5 programs. The first, fourth, and fifth are more aligned toward nursing. The second or third are more aligned toward behavioral health. But the first one can actually address both, and I'll talk about them one at a time. So first are 2 new programs. The Earn to Learn Nursing Education and Acceleration Program is a new program. It is intended to make it possible for someone who is already employed in a medical field, such as a nurse's aide, for example, to continue work up to a point and then continue earning money while they take their clinical training. So they don't have to quit their job and lose their income while they're doing their clinical hours like I talked about before. So again, Virginia's got 6,000 open permanent nursing positions. Again, 40% vacancy in the state mental hospitals. We need nurses in Virginia. Earn to Learn would provide grants to the educational institutions that provide nursing degrees. They would in turn be required to pass that money on to healthcare systems that employ individuals that are interested in working in nursing. So these people that work in some level of healthcare to start with want to be in their nursing degree. When they get into their clinical phase, they would continue to earn in their existing profession. So they still get a paycheck from their employer while they're in their clinical nursing training. And some of the funds can also be used to establish or enhance staffing, programming, etc. The deliverable for this program is the schools would be required to demonstrate an increase in net number of graduates. So there's no smoke and mirrors here. If you normally graduate, pick a number, 100 nurses. If you're going to take this money, and again, the money goes to the educational institution, you need to demonstrate you're turning out more nurses and you're doing it through this program. So that would be a requirement. And if everything works according to plan, there could be potentially up to 1,200 graduates a year Again, it'll take a long time to fill up not only the 6,000 vacancies plus the retirements coming, but this is intended for us to be able to at least not lose ground. Next program, this is another new one, although it's similar to an existing program, Psychiatric Nursing Graduate Loan Repayment Program. A request for that is $5 million from the general funds. Again, remember the vacancy rate for nurses in the state mental hospitals is enormous. So what this program, proposed program, would do is increase the volume of psychiatric nurses by loan repayment incentives. So in exchange for a 4-year service obligation, psychiatric registered nurses and psychiatric nurse practitioners, so you get prescribers mixed in this too, would receive 25% of their loan balance each year during their 4-year obligation. The intent being to work out that they've paid off their entire loan after they've finished their 4 years. And after they've spent 4 years working in Virginia, the expectation, the hope at that point is they'll stay. So they'll have established a home and a profession and so on. The estimate is we could provide 70 awards over 4 years. And again, this particular program is similar to one I'll talk about shortly, which was aimed more at providers. Again, $5 million, 70 awards. If you do the math, it comes out to about $30,000 or so each. And that's for a 4-year obligation. Speaking as someone who was on an Army scholarship for medical school, I had a 7-year obligation when I was done. Same concept. So augmentation of 3 programs are next on the list. The first is the Behavioral Health Loan Repayment Program. And this is a request of $2.5 million. And the intent is to increase the number of behavioral health providers, particularly in underserved areas of the Commonwealth. So the rural areas, the African American communities, other communities of color, the traditionally underserved areas, and the ones that have the 41% that are a mental health professional shortage area that I talked about before. So this increases funding for an existing program. In FY 2023, that program provided 49 incentive awards. The existing funds would allow 80 additional awards. We'd also are asking to raise the maximum loan repayment from $30,000 to $50,000. Again, if you're paying off somebody's medical school loans, $30,000 is a pretty small piece of it. $50,000 is more likely to get more incentive out of the program. And we're looking for some of the specialists that we have the least of: child and adolescent psychiatrists, and then psychiatric nurse practitioners, and adult psychiatrists. And again, funds would only be available to individuals agreeing to work in underserved areas. There is a service obligation. This one comes with either 2 years full-time or a total of 4,000 hours, which is 2 years worth of work, and it can be spread out over as much as 4 years. Again, for the initial application cycle, there were 289 applications, but the money ran out after 49 awards. So there seems to be plenty of demand there, and we're asking for an additional $2.5 million to make that work. I talked earlier about not having enough clinical teachers or preceptors. Big barrier toward completing nursing. The current program that exists was funded with $500,000. The current incentive offered to a nursing preceptor is $1,000 for a semester. In order to get that full amount of money, the preceptor has to put in 250 preceptor hours under the present program. And you can do that math in your head. That's $4 an hour. Now, anybody that's ever been a teacher knows that teaching is a labor of love. Nobody does it for the money. But $4 an hour is stretching that dedication a little bit. So what we're asking is to quintuple the total amount that's available to offer to $5,000 a semester for the same number of hours. Again, the expectation is we'll get more takers, we'll have more preceptors, we'll produce more nurses.
We're approaching minimum wage.
Yes, ma'am. All right, and then my last of the 5 programs is a nursing scholarship and loan repayment program. This is a request for $1 million. These are primarily scholarships rather than loan repayment, and again are funding licensed practical nurses, registered nurses, nurse practitioners and midwives, and nurse educators. And again, we've been able to fund 800 in the past. Obviously, this is since it's an LPN program, it's less expensive than some of the ones we talked about. But we can certainly increase the number that we fund, ideally to 2,400 a year.
Question.
Yeah.
On before we leave the nursing area, on the education program, where you've got the 30 million price tag.
Yes, sir.
In the detail on that, how is that money to flow? Do the institutions have to come up with some kind of proposal? Or
Correct. And it is, if you read the verbiage, it's left to the Virginia Department of Health to actually set up the specifics of the program. It's modeled after, I think, 6 existing programs that already are present. But the money would flow to the degree offering institution. So the University of XYZ would get the money, and they would then come into an agreement with the ABC health system, who is employing the nurses' aides, maybe the housekeeping staff, the clerks, whoever's interested in becoming an RN, and then they would then continue to pay their employees while they do their clinical training to become a nurse.
Okay, they would still maintain their employment.
Yes, sir.
Full-time employment, and would be working with one of the institutions for
Right.
the degree.
Right, because the health system would be getting the money to pay them from the educational institution.
Right. That's the extent of it, or would they be building infrastructure? Is that 30 million going to that, or what?
Yeah, there's some of it would go to infrastructure. So for example, you need clinical space, you need materials, that kind of thing. But the main intent is for the money to flow through to allow the employees to continue working or to continue earning, and not have to drop out of their job in order to take on their education. And a lot of folks, they can't afford to do that, so they just won't do their clinical training.
Okay,
Yeah.
thank you.
Right. All right. The remaining amendments I've kind of compressed into a couple of tables. The first one involves the Drinking Water State Revolving Fund. This is one of the best deals that has come along in a long time. We come up with just under $3.4 million, and Uncle Sam gives us almost $92 million. And that comes from, again, the bipartisan infrastructure bill that was passed a couple of years back in Congress. And we have put that to good work, as you'll see in some of my later slides. That particular funding, the $3.3 million, is for this year. It's a 10% match for the funds that are going into the revolving fund. Obviously, that's not the total amount of the money, but again, $3.3 million to get $92 million, pretty good deal. The next one also applies to the Drinking Water Revolving Fund. Since 2019, at least, there have been apparently some aspects of how the fund was managed that the EPA would have liked to have seen done differently, and that led them to declare a reversion of their federal funding to the tune of $1.18 million. And while they have promised that money, once they get it, will go back into the revolving fund, we still need to pay for it ahead of time, and that's going to have to come out of Hyde, so we're requesting help with that. And again, that's money that's put out that we'll get back in the revolving drinking water fund and do a lot of good, as I'll show you in a bit. Next one is asking for additional support for increases in rent. So we don't own, we probably own one or two of our buildings, but most of the local health districts do not own their real estate. They rent it. They rent it from the local governments. They rent it from the private sector. Rents are highly variable, and we don't have a lot to say about them, except they have gone up lately. So we have a need for extra money to pay rents. The state portion of that would be $943 million. $942,000 and change. And then the $698,000 would come from the local match, so from the communities involved. The next line item is in response to a deficiency found in 2 different audits that we do not have a permanent cybersecurity threat management position. So we want to go ahead and ask for the money from general funds to make that position present. Thus far, we've used grant funds to hire contractors. Those grant funds come from that yellow slice of the pie that's going to disappear, so we're asking for money from the general funds for a permanent cybersecurity threat management position, not only to make the auditors happy, but also to keep us safe. Next line is a request to take some of the state version of our state portion of the opioid assessment funds for specific efforts, again, fentanyl response efforts. That's $7 million. A lot of that will go to buy naloxone, to be perfectly honest, but some of it will also support comprehensive health reduction programs, which have been the most successful distributor of naloxone, as well as fentanyl testing strips and other methods of reducing risk, along with testing for other conditions, treatments, prevention, and referrals. And again, that $7 million was over on the right side of the pie chart. Tuberculosis cases are up. Tuberculosis drugs are now more expensive. We've been receiving $50,000 a year. That's not going to be enough. We are asking for another $50,000. Tuberculosis is something that I don't know if I'm the oldest person in the room, but it was still endemic in the United States when I was born. Some fairly well-known people either died from it or died with it. Hank Williams Sr. had tuberculosis before he died. We don't want TB to come back, so another $50,000 to help us treat the known cases that we have and also offer treatment for the latent disease that could turn up with cases later. You probably have all heard that our medical examiner salaries are substantially less than some of our neighboring states. So my medical examiners on a regular basis are getting offers for a raise of anywhere from $50,000 to $100,000 if they'll move to places like Baltimore or Pooler, Georgia. We are supposed to have 20. We now have 11. We have lost 5 in the last 3 years. We have not been able to hire any with what we're offering. So we're asking for money to raise the salaries in general so we can keep them, and also to make the positions more attractive so we can start to refurbish or to reconstitute some of our lost staff. This is a critical need. We can't afford.
Critical need. How many more you think this figure is going to get you? What are you gonna...
Well, it depends. So if it's just 50,000 per, 50,000 times 20 is $1 million, and then the remainder of it would go toward raising the salaries for some of the support staff, which are also below the competitors. So the next, ma'am, go ahead.
If we wanted to be competitive with, say, North Carolina or Maryland, what would we need to do?
We need to be offering.
This doesn't sound enough.
It's certainly better than nothing, but we've raised our offering salaries from about 2.25 to around 2.5, so 250, 255. That still hasn't gotten any takers. We need to get closer to the 300,000 mark in order to compete. We definitely.
Qualifications. Sounds like a good job.
Well, you have to be number one. You have to be a pathologist, which takes a special kind of person. Dr. Gormley in the room.
Okay.
And then to be a forensic pathologist on top of that, which is additional training. Number one, takes an even more special type of person, but it takes a hugely dedicated and highly trained individual. And it's not an easy job. I mean, it's extraordinarily challenging and demanding.
There's a scarcity, I guess, in the profession as well, then.
Yes, very much so. It's another one where there's a nationwide problem. So, and there's just no substitute for a forensic pathologist when you really need to know what happened especially if you're suspecting foul play. So the next line is in answer to a change in the code. There's a requirement that every emergency department has a sexual assault forensic examiner, so somebody who's not necessarily a physician, but can do a forensic exam for someone who's been sexually assaulted or suspected of it. It's good that that requirement is there. It should be there. The training is necessary. We looked at hiring a permanent staff to train the trainers. That would have actually been probably $130,000 a year for every year. What we've opted to request instead is to purchase a training program that we can then share with the regions and the ER. That curriculum will cost us $125 for the first year, and then it'll run about $15,000 a year after that to continue using it.
Senator Al?
Is there also a lack of examiners and specialists for child sexual abuse?
I'm quite certain there are, ma'am.
But that's not under your...
Well, it is, but it just doesn't fall under this particular bill. Yeah.
But is there anything additional for that in the governor's budget?
Not specifically, but we'd certainly be happy to look at it.
If you could look to see what would be needed.
Well, let me make a note of that, because I'll need to look at the curriculum. It may well be part of the curriculum. I have to confess I don't know. Child.
I don't necessarily mean a curriculum. I mean having the staff.
Well, the curriculum would be used to train the staff, right? The most common person is something that's referred to as SANE. It's a sexual assault nurse examiner, but it doesn't have to be a nurse, so that's why that term is SAFE now, forensic examiner. But I'll get back to you, Senator.
Yes.
Before we turn the page, I wanted to ask about the opioid settlement funds, the $7 million. I was curious, that's $7 million. How much did we get in the settlement?
So the total settlement over 18 years was $540 million. And not every one of the cases has been settled yet. That was just so far. So if you divide that by 18 years, you get $30 million a year. Now the reality is that some of it's front loaded. That money there's a legal requirement to disperse that money. A certain amount of it initially goes off the top to localities. Another section of it goes directly to the state, and I believe that's what we're asking for a share of right there. And then the remainder of it, which I think is 55%, goes to the Opioid Abatement Authority, which was created recently. And then the OAA then takes their money, and they have to distribute it according to specific rules as well. There's another aliquot that goes to the localities. And most of these dollars have to be spent specifically on opioid abatement, addiction, et cetera, treatments, preventions. You can't just go out and build a bridge with it, for example, which I gather was done with the tobacco money fairly often. There are a lot of rules and regulations placed on these dollars.
Thank you.
Yes, sir.
Mr. Chairman, just real quick, just to note for the subcommittee, next Monday there are two opioid-related bills. One of them that's related to the 15% state share. So the Opioid Abatement Authority, they're going to come and provide a brief presentation of all that as well.
Okay, good.
All right. So last four items, these actually don't involve asking for any particular dollars. The first one refers to a last year. One moment. What did I do? There we go. The last year of a grant, which is part of the COVID package. And it's appropriation for epidemiology and laboratory capacity, or ELC. A lot of it involves testing and some treatment. And it has a very broad reach. So all the school testing programs, a lot of them are funded through this, for example. And ELC funding has a baseline function where we look at trying to avoid disease spread, emerging diseases, the flu, for example, but there's an additional piece that was added on for during the COVID pandemic, and this money is left. The federal government has given us permission to spend it up until the end of FY24, and we're asking that to be ratified by the General Assembly. Okay. The next line is a request from the administration to prohibit the expenditure of public funds for abortion services.
On that, we've had language in the budget the last few years to get a report on actually how many services like that were provided from Medicaid funding. Is it ring about 20 a year, something like that?
Yes, sir. This actually isn't Medicaid. This is direct general fund. It runs between 20 and 40 total.
Yes, Senator McClellan?
I have not looked at the language, but in the past, the language to remove public funds has been limited to, has tracked the Hyde Amendment. Does this language do this, or does this prohibit funds altogether?
Senator, I'd have to get back on you on that. Back to you, rather. I want to say it's altogether, but I'm not certain of that, so.
Mr. Chairman, yeah, I mean, it's, you all have seen this over the years. So what it does is it strikes the state statute that's in that language. So basically, it limits it so that no expenditure from the Appropriation Act can be in accordance with the Hyde Amendment. So it does mirror what the federal government does in their appropriation bills. So the one exception that Virginia had in state statute is gross fetal abnormality.
Fetal abnormality, and
Which is-
we currently are,
Correct.
that's where we are, and
And that's what's not in the budget, proposed budget. Right.
Okay. The next request is to extend a deadline for a Treasury loan, and again, this costs no dollars. The background on this goes back to the large COVID vaccination sites that we set up around the Commonwealth. We set those up on the promise that the Federal Emergency Management Agency, or FEMA, would pay for them for us. The total bill for all of those was in the neighborhood of $93 million for the amount of time we set them up. FEMA funds flow very slowly. They flow a lot more slowly than the invoices from our various vendors, people that needed to be paid. So we paid them from various sources, waiting for the FEMA funds to come. And unfortunately, the FEMA funds were slow enough that we had to take out two different Treasury loans totaling $62 million. We've paid one of those off now that the funds have been mobilized this year, actually within the last 6 months. We have about 2/3 of what we need to pay off the other one. We're just not absolutely sure we're going to get it done by the 30th of June, so we're asking for an extension now so we don't have to ask for one later. But every last penny will be paid off. There's no question about that. And then the final request is just to correct an accounting error. The State Office of Rural Health grant matching funds were placed in the wrong program area, and I think it was 108 as opposed to 400 and something. The accountants would know specifically, but again, no additional funds, just to place funds in the right account so that we're charging them to the right thing. And I want to finish up with a little bit of good news. These are the Your Tax Dollars at Work slides. I would start off by saying, since these are all environmental health projects, clean water, safe food, and sanitation is what brought the United States out of the 19th century. It's what raised our life expectancy from 47 years in 1900 to 70 years in 1960. And that was before most of our modern medical miracles came into existence. We obviously need to not take our eye off that ball. Sanitation is also what separates us from some of the developing world countries as well. So this is what we don't want. This is called a straight pipe. That's a raw sewage landing on the ground. For this fiscal year and for next fiscal year, we have from ARPA funds $5.75 million per year available to repair failing septic systems, replace inadequate wells and private water supplies, and help people properly abandon ones they're not using, and to some extent connect to public sewer or water connection. These are available to people up to 200% of the federal poverty level. I can tell you this is a wonderful program. From my days as a district director, it was heartbreaking, the people that would have their septic systems fail. They would be cited, and they would just say, I can't afford it. It's $10,000, $20,000 for a new system. I can't do that. Well, now we can. So I will happily say that the $5.75 million was spent in 8 months. So as opposed to so many programs that have trouble spending all their money, this one spent it all and could have spent more if we'd had it. This map shows the location of the beneficiaries. Again, you can see they're mostly rural areas. The red is an application that's been received. Green is one that's been already installed, and yellow is one that's in progress. There have been a few that have been denied. Those are the black markers. Those were marked. I mean, those were denied for 3 reasons. 1, they didn't meet the income level requirements. 2, they wanted a new well and their present well was still functioning. Or 3, they wanted a new septic system and their present septic system was still functioning. Otherwise, we were more than happy to put the projects in place. The other thing we do with these maps, and these are important, is it's an equity tool. So we want to make sure that we're not putting all of our programs in the Southwest, for example, or in the central part of the state. And you could even look at this and say maybe we need to pay a little more attention to Southside, because I think these issues are all over the state. So again, just one way we keep an eye on not leaving people out. The next one is the drinking water infrastructure. 2 examples. One is a town, one's a county. So Boone's Mill, which is out in Franklin County, for just under $78,000. After the Water Authority assumed ownership from the town's water system, and this happens a lot, they repaired a water line that had been damaged based on vehicular traffic, put in new distribution lines, and 350 citizens benefited with reliable drinking water. Likewise, the town of Coburn down in Wise County, again, much larger amount of money because they had to replace 2.3 miles of water line and all the appurtenances attached to it. This involved that drinking water state revolving fund. Again, so that's some of that $90-some million we get from the federal government. And again, 450 rural and remote residents benefited, again, with reliable, safe drinking water. Again, a map showing where the projects are. Again, need to go back and take a look. There are some areas on the map that don't have a lot of projects, and maybe they should. So something that we, again, use to keep an eye on ourselves and make sure we're being equitable with how we distribute these benefits. And this is just an estimate of the blue line is the reimbursements that have been the awards that have been dispersed to date. The orange line is cumulative, and the black line is an estimate of the expectation of increased demand. Again, the drinking water revolving fund has, $80 or $90 million in it. We haven't even broken the $10 million line yet. That concludes this presentation. What are your questions, ladies and gentlemen?
Are there additional questions for Dr. Green? Okay. Well, we certainly appreciate you being here today. We are in the early stages of budget development, which is scary because 2 weeks from yesterday we'll be in the final stages of budget.
That is scary.
So we'll be working with you on some of the critical issues here.
All right. Senators, thank you very much.
Thank you. I think what we'll do now, I see one patron here. Before you do your presentation, I think while we've got a quorum here, we'll take bills as we can, and then when we have some empty space, we'll let you begin. Barbara, Senator Pavola.
Have one bill before you, Senate Bill 926, the Emergency Department Care Management Grant. This proposal is a recommendation from the Joint Commission on Health Care, and the intent is to really reduce emergency room use for those individuals who are using the emergency room as their primary care conduit. So the grants would be available two hospital systems, and, you know, they would be expected to come up with ways to determine what barriers individuals are facing, so they can't get care in the community, or they don't have a medical home. They'd be looking at social determinants, which are oftentimes barriers to connecting an individual with a medical home. The intent is really good. We're hoping that you will fund it. I did ask for $5 million, I think, in the second year.
I think, I don't know, do you have people here to speak? Well, no, we're going to do that. This has already gone through the committee.
Yes, it
Right,
has.
gone through a committee, so we need to talk about the finances. And I think our, Senator Pavola, the situation we're in here today, even with things that have significant merit, we haven't made an initial pass through because it's hitting us kind of early here. And I don't know whether Senator Barker and Senator Howe have a different opinion, but if,
Early bird gets the worm, so
well,
I'm hoping
if
that I get my worm.
if we do anything at all today, it would have to be subject to contingency clause.
I understand.
And I'll look to the other members as far as whether or not you want to try to do something in this area.
What was the cost?
I put in a cost of $5 million in the second year for 2024, but really, almost any number would play.
And Mr. Co-Chair, can I ask Senator Favola, do we know with that amount of money or how many people or hospitals that actually might serve?
I really don't know how many, and I
Okay.
don't know what the size of the grant would be, but it was our best guess that we could provide a reasonable grant to a reasonable number of hospitals. I just don't have that information.
Right.
I apologize.
I know you've been doing some good work with the hospitals, Senator Favola, and this is an issue where some hospitals are maybe doing some pilot programs already in terms of dealing with these frequent flyers.
Yes, yes. I mean, you do make a very valid point. I mean, there is an incentive on the part of the hospitals to
Right.
reduce the number of frequent flyers. But we're hoping just a little money from the state might even bolster their efforts more, because we all benefit, the state benefits considerably too.
Okay.
Frequent flyers.
Y'all want to keep
Oftentimes
this
these are
one
Medicaid.
alive for the time being by putting a contingency clause on it, or?
Yes, I was just going to suggest that, actually.
All right. All right. So moved. Is there a second? Okay. Motion properly supported to add the financing contingency clause. And then, all those in favor say aye.
Aye.
Aye. Okay. All those then in favor of reporting with the amendment signify by saying aye.
Aye.
All those in favor of recommending reporting with? Aye. Okay. We'll get coordinated
And
here momentarily.
Senator Deeds votes aye.
Okay, all right, we will, this will be subject to, and we'll need to kind of work on a spreadsheet or something with you,
Yeah.
Barbara, to see what we can come up with.
Okay.
Working with the hospitals, if they want to come around and talk to us about this,
Okay.
we'll see
Yeah,
what we can come up with.
definitely.
Yeah,
We're willing to work with you.
okay, we won't take testimony now, but I see some faces out there that can bring us some numbers and see what we can do. Okay, thank you.
Whatever the finance committee needs.
All right, Senator Cosgrove? Yeah,
No, he's the chair.
right,
He's chair.
okay. If you would turn your microphone on there.
Thank you, Mr. Chairman. I have before you Senate Bill 1234.
Oh, lucky you.
Kind of easy to remember, yeah. It's two bills, you know, that are really cool. That one and 666, and I don't want the other one. Mr. Chairman, Senate Bill 1234 deals with electroencephalogram-driven combined transcranial magnetic stimulation. Basically, this is a newer technology that is being currently used to help treat post-traumatic stress disorder and traumatic brain injury in a lot of veterans. It also has had tremendous success rate in treating autism, believe it or not, as well as an 83% success rate in substance abuse and opioid dependence. That 83% is sobriety and or greater than 50% improvement in the Track 9 scores. This particular technology is being used by some of the military in Hampton Roads. I know that some of the members, some of the team members down there have been using this right outside the gates of Oceana. I have a gentleman here if you'd like to hear from him. His name is Brandon Solo. He actually is very, very familiar with this particular device and its efficacy. And I really hope the committee will take a favorable look at this. This is really something that's going to be of great benefit to our veterans, besides helping people with substance abuse issues that we know we have right now, which is significant. So would you care to hear from Mr. Solo?
This was heard in education? Has this bill been previously heard?
Yes, sir. It was heard in Ed and
Okay,
Health.
okay. Well, take just a comment if you got somebody here. We
Absolutely,
normally
yeah.
don't take
It
a
won't
whole
take
lot of
long.
testimony on this
Brandon, would you
subcommittee.
come in here?
Thank you, Madam Chair. Thank you, Chairman. Thank you, Committee. I'll be brief. My name is Brandon Solo. I was medically retired as a Ranger at our 1st Ranger Battalion in 2011, and then I was hired by SOCOM to develop the Wounded, Ill, Injured, and Performance platform for our SEALs in Virginia Beach. So my job was to find cutting-edge technologies to keep our guys on the battlefield. We found this technology in 2014. We started sending our Tier 1 operators out to California with incredible success. To speed it up for you all, we have this technology down in Fort Bragg. We're working with SOCOM. We're working on some initiatives with the National Guard. This bill was approved with bipartisan support in Ohio, so we're replicating the same thing. And what it means to us is, at the end of the day, we're trying to stop the suicide epidemic. We're trying to help our veterans and our first responders and our people suffering in Western Virginia with opioids. So I think it's a great bill, doing great things, instead of just holding it in the special operations community, sharing it with Virginia. So thank you for your time.
Thank you.
Thank you.
Senator Cosgrove, I think the chairs of the full committee have reviewed this one previously as well, and it seems this is scalable, that we think we can do something.
Okay.
And,
Anything would be a real benefit to the folks that really need this, Mr. Chairman. I appreciate that.
okay, so I guess if we make a recommendation to advance it, it will not be with a specific amount.
I understand.
We may, Mr. Chairman, be suggesting that there be pilots in Hampton Roads and in Northern Virginia, which is.
Actually, Madam Chairman, that's a really, really good idea. Now, of course, we have a lot of active duty, where we are, but you have a whole lot of active duty in Northern Virginia as well. And those folks coming, out of Bragg, they're going to Belvoir, they're going to the Pentagon, they're going all kinds of places over there. So that's a really good idea.
Okay, what's the pleasure of the committee?
Do we need to put the clause on there?
I think with the understanding that
That-
it's scalable, we'll have to figure out how much we can devote to it. It could be recommend reporting. Is it?
We recommend reporting.
Okay. Motion properly supported that we recommend reporting. Any discussion? Hearing none, all those in favor signify by saying aye.
Aye.
Any opposed? Okay.
I'm extremely grateful for this. Thank you so much.
Proxy for deeds.
Thank you, Senator Cosgrove. Okay, I don't see any other patrons right at the moment. Okay, thank you. Mike, do you want to go ahead and begin your presentation? I think what we'll do, Mike, when patrons come, we will suspend your presentation and take them up and then move on.
Yeah, thank you, Mr. Chairman. That was actually my thought as well. I would give you a break from the budget stuff. So, and to be honest with you, I will be fairly brief as well. Some of this you've seen in the full committee. Basically, this is really just a slightly expanded version of what we presented to the full committee. The overview of the governor's budget for health and human resources. So as you recall, basically, it is a net decrease of $113 million. General fund over the biennium, and an increase of $4.5 billion non-general funds. As you well know, that the Medicaid has sort of been a net giver in recent years because of the public health emergency, and basically where Congress had extended during that public health emergency a 6.2 percentage point increase in the federal match rate for Medicaid. So again, you can see additional quarters are assumed in the introduced budget that help to bring it to a net savings. So there, of course, there is additional spending in the introduced budget. One of the largest areas is within just HHR, over $153 million in additional behavioral health funding. There's additional funding for the Medicaid forecasts and the healthcare fund, which is used as state match for Medicaid. Then, of course, $48.5 million for healthcare workforce programs, which I won't go into as much detail today because Dr. Green has already kind of done that. There's $41.6 million to increase Medicaid personal care rates by 5%. $15.7 million for the caseload growth in the TANF unemployed parent program, and $15.1 million to add 500 DD waiver slots. So the savings amendments total about $538 million. So, Mr. Chairman, would you like to?
It might be a good day. Senator Peterson, you got a bill? I think I do. Okay. We're getting a briefing, so anytime one of y'all wander in.
Why don't you all brief away?
No, well, if you're ready to go, anytime.
Okay, all right. I'm looking for my backup. Here we go.
Okay.
Senator Peterson, if you want to.
Oh, I'm sorry. I have Senate Bill 957, which is the Prescription Drug Affordability Board. And I made this presentation in Commerce, but I'll sort of give you the short version. Basically, we've had a sea change in how we deal with prescription drugs and how governments purchase prescription drugs, and it really had to do with the federal legislation that was passed last year, the Manchin-Schumer bill, which allowed the federal government for the first time to negotiate with the large pharmaceutical companies regarding the purchase of drugs for Medicare. And as a result, because of those negotiations, they're able to establish something called the UPLs, or upper price limits, which basically set a ceiling on what they will pay for high-demand, high-cost drugs, pharmaceutical drugs. And last year I had this bill, and it was not quite ready for prime time, so we didn't actually present it to the Commerce Committee. But now it really is ready for prime time, in that we could, at the state level, establish a state board that effectively would adopt the UPLs and could customize them for Virginia and utilize them in two respects. One, for our Medicaid purchases in order to protect our state taxpayer. And secondly, we could use it on the private market. And there is U.S. Supreme Court authority saying that we have the ability to regulate drug prices within our state. And that's effectively what this bill does. It set up a prescription drug affordability board, and within sort of the intricacies of the bill, it talks about meeting 4 times annually. It talks about actually being able to adopt the UPLs. I think it calls it this is line 237. Board may adopt the Medicare maximum fair price, which is set out in the Social Security Act, which again was for Manchin-Schumer. But the whole idea is that we would use the Prescription Drug Advisor Affordability Board to basically put a cap or put a lid or just rein in prescription drug prices, and that would have a benefit to our consumers. It would also have a benefit to our taxpayer. And I know someone's got the numbers, which I don't, but we spend a lot of money on prescription drugs through Medicaid. So that's the sum and substance of the bill. And I got some people a lot smarter than me here to speak to it.
Okay. It's a pleasure, committee. We want to limit testimony here, but this is a heavy lift, I think, for us. Y'all want to hear some testimony?
Sure.
I want to do that. Okay. A little bit.
Come on up. Yeah, please.
Hello, everyone. Jared Calfee with AARP Virginia. Hopefully the people that are smarter than Senator Peterson are in line behind me to speak.
You got a whole room.
But I'll just say that, prescription drug costs are a huge problem here in Virginia. We've conducted a survey that has shown that 1 in 4 Virginians are not taking prescription medications as prescribed due to cost, and we view that as a tremendous problem. This is not a silver bullet to solving prescription drugs. There is no silver bullet, I'm afraid, but what this is a good common sense piece of legislation that will help us deal with some of the highest cost prescription drugs, things that deal with life-threatening illnesses like cancer and diabetes. It will save taxpayers money by saving state and local government money on Medicaid program and health plans. So this is a bill that I think is good for everyone and is a good first step in addressing the skyrocketing costs of prescription drugs. We've talked a little bit about the rate at which prescription drug costs are increasing. In an era of high inflation, it's dwarfs even the highest rates of inflation. We're talking about 8.6% inflation and 30-some% increases in prescription drug costs. So it's something that we'd like to see addressed, and we appreciate Senator Peterson for carrying this.
Could I ask a question?
Senator Howe?
Do any other states do this?
Yeah, a number of other states have created these boards. The ones that we reference the most because the model that we're working on here in Virginia is closest to is Colorado, Maryland, and Washington. All three have the Prescription Drug Affordability Board with the ability to set the upper payment limit that Senator Peterson talked about.
Okay.
Excuse me? Maine may have one, but I think their structure may be a little. There's several other states that have them structured a little differently than what we're doing here.
I think what's going to happen is now that Manchin-Schumer's become law, I think a lot of states are going to move towards this.
Okay. All right. If you've got others, and if just make brief remarks, because I think this is kind of an introductory course for us right now.
Hello. I'm Rena Hicks. I'm the Executive Director for Freedom Virginia. We strongly support this bill. I do have a couple of money stats if you want to hear, but I also want to stay brief. But one example is in fiscal year 2022, our Medicaid program spent $2.2 million in its Medicaid FFS program on cancer drug Zofran. And if we compared that, the price of Zofran in the U.S. to those of in Canada, for example, Virginia could save anywhere from $240,000 to $1.6 million just on that one medicine having the adopted policy of an upper payment limit. So it is a big money saver, and this is a huge issue for Virginians.
Thank you.
Mr. Co-Chair, members of the subcommittee, my name is Abigail Thompson, here representing the Impact Project. We very much support this bill for the opportunity for transparency and accountability it will provide. Thank you.
Thank you.
Good afternoon, Mr. Chair and members of the subcommittee. I'm Katie Boyle with the Virginia Association of Counties. This issue was brought to us by one of our member counties last fall, and we are supportive. There was a lot of discussion about the pressures on individual Virginians' budgets, but also the pressure that prescription drug costs are placing on county budgets through insurance for county employees. So appreciate your consideration. Thank you.
Thank you.
Briefly, I'm Karis Mitchell on behalf of the Virginia Catholic Conference. We also strongly support this bill in an effort to make the prescription drugs more affordable for all of the reasons you all have heard. Thank you.
Okay.
I have a different viewpoint.
You're on the other side? Okay. All right. Okay. I would like to hear just a couple brief comments on why it's not a good idea.
Come on, Chris.
Good afternoon, chairs, members of the subcommittee. I'm Chris White with the Vector Corporation. I represent Pharma. I think we all share the goal of lowering healthcare costs for all Virginians. We would just make two observations about this particular bill, and we think that now is not the time to move forward with legislation like this. Earlier it was mentioned there are 3 states that have passed proposals like this: Washington State, Colorado, and of course Maryland. I've got some figures in terms of the cost that boards like this have cost to the various states. Washington State was about $2 million to establish the board, and then another $1.3 million in ongoing costs and operations per year. Colorado, a little differently, about $850,000 to establish the board and about $500,000 per year. Maryland is the one that you all hear the most about. They passed their legislation in 2019. They've spent about $2.5 million. I'm not aware of one report that they've produced around drug affordability, nor am I aware that they've saved a patient any significant dollars. The other piece that I would mention is that the feds have passed the Inflation Reduction Act, and in that federal bill, there are price controls and upper pricing limits. And so we believe that it would be more prudent for states to take a pause, understand how that policy is going to be implemented before legislation like this is passed. Finally, I'd mention that even our own Joint Commission on Health Care, when they were setting their work plan for the upcoming year, they had an affordability study proposal. They decided to take a pause on that and get some presentations around how the IRA is going to be implemented. We think that would be a much more prudent way to proceed. Thank you all for your time.
Right.
Can I ask a question, Mr. Chair?
Sure.
Yeah, Chris, we heard that prescription drugs are going up by as much as 30% in a year. So what is your counter proposal on how to keep those costs from going up so much?
Chairs, Senator Eben, I think that's a great question. I'm not familiar with that particular statistic, nor do I know where it came from, so I can't really say whether or not that's an accurate number. But I will say that there are some proposals that are going to be before the General Assembly, Senator Mason, I think, has brought forth an excellent idea where he has asked that a PBM or a carrier or an insurance plan who's negotiated a rebate with the manufacturer pass 80% of that down to the patient, so that patients are actually getting real savings as opposed to a proposal like this.
I understand that'll could raise premiums because the money goes into the rate base as a whole now. But you said you're not sure that it's 30%, the cost of prescription drugs a year, that it's going up. Do you know what it is going up?
Chairs, Senator Evan, I'd be happy to get that information. I don't have a particular number with me today, but I'd be happy to provide that to your office. Yes, sir.
Senator Peterson, my thought on this, I haven't done my homework or due diligence. I really don't like to invite additional conversations too much, but I think we really need to work on this more. It's a good concept, but I hear conflicting points about it.
You know, can I respond, Mr. Chair?
Sure.
I think what Chris said was telling, and I'm going to use it against him. I agree. The Inflation Reduction Act is critical, and these UPLs will be established. And the question is, are we going to be in a position to take advantage of them, or are we just going to look on? Right. And all we're doing is setting up a structure that we can adopt them and start saving money. And by the way, this doesn't take effect till January 1, 2024, which means it'll be 18 months after Manchin-Schumer. So we're not rushing into anything. So I think, look, we talk about this, okay? I may not be around. You may not be around, but let's
Right.
leave
I'm
it.
talking about a week, not a year.
Oh, that week? Yeah, sure. Okay. All right. I'm sorry.
I hope I'm here next Monday.
Yeah, that's true.
Just to do due diligence,
Fair
because I think the conversation has merit, and I wanted to make sure I don't just vote.
I thought you were going to PBI me. All right, I got
no.
Okay,
not going to do that. Not going to do that. Did you have something to add at this moment?
Yes. Just wanted to test.
Pro con?
What's that?
Or pro or con?
Against.
Against? Okay, just quickly put an issue out here, because I really would like a week to see if we can figure out a way to make sure this makes sense.
I can also come back in a week.
Well, I don't want to hear from you in a week. I want to hear with. I want to hear from you between now and next week.
Okay.
In other words, I'm inviting stakeholders to come around and talk to us about this.
Okay.
That's what I'm up to.
James Williams, Deputy Secretary of Health and Human Resources, here on behalf of the Governor's Office.
Okay.
So just here to say the Governor strongly opposes this.
Okay, that's good to know.
And the reason is really that we think it's really broad in its reach. So it's employer sponsored and employer regulated. I mean, so we're talking about the entire commercial market with some small exceptions. And in general, I mean, even the IRA, the Inflation Reduction Act, took a very tailored approach. It basically said, the top 50 Medicare drugs in terms of spend and price that the Secretary of Health and Human Resources would actually take a look at in terms of limiting prices. And here we're talking about an upper bound price on every drug in the entire market potentially. So we're just concerned about how broad the authority of the board is.
Okay.
Also, this is a really complicated space. We don't think that a part-time board should be the one to actually make these recommendations.
How about a part-time legislature? I'm sorry.
Well,
Right. Excuse me, have y'all dissected it enough to see if there's some common ground in there? You want to review the bill and see if there's some ways to improve it?
would certainly be open to talking more.
Okay.
About that, but
Well,
in general, I just think that it's a really complicated space where you talked about the prices going up. Your quote is list prices, and the reality is you have rebates behind the door, which you just talked about, and the real price is actually lower than 30-something%. It's somewhere between 0 and 30%. That's because there are secret rebates that go back to the employer, whoever's actually paying the bill. And those rebates create a really competitive market, to work against the pharmaceutical companies. And when there's 2 or 3 drugs that are on the market, that's actually a very competitive market. So that system works reasonably well, even though, admittedly, we can't always see the real price.
Well.
So, and I know that irritates people. That might be a different issue, to address here. But, the reason that the Inflation Reduction Act actually took directly address the top 50 spend drugs is that those are sole source drugs. There are no competitors, right? So that's why it was very tailored in its approach. And this is just broad reaching for the entire commercial market, and it's just too far.
Okay, fair enough. Again, Senator Peterson, not with being the end, but rather just a way for us to
Sure.
educate ourselves more adequately and see if there's common ground.
I appreciate my colleague coming to speak, and this is the first I've heard the administration's opposed, which that's obviously significant. I do find there's limitations as to which, it's not going to be every drug.
Right.
It's going to be a fairly specified category of drugs, but, I need to get into the weeds on that, and we can do it together.
Right. I think that's where we, with the committee's concurrence, is that?
I agree, but I just wanted to say that I think what's really going to be crucial is figuring out exactly how the federal programs and proposals intersect with what this bill is trying to do. Because I think he's going the right direction, but I don't want to stumble.
Senator Barker?
At the federal level, they've already started outlining which drugs they're going to look at and when they're going to start to make the assessments, and involve the drug companies and everybody else is providing input there. But even that's going to take a year or two to get it off the ground. And then they're going to do 3 drugs or something in the first year and 5 the second year or whatever, something like that. It's sort of a gradual phasing in. And so one of the things that we could do is sort of piggyback on that. So maybe that's something that you could look at there, sir.
Okay. All right, there are no objections, and that's what we'll do, if we can work together here and see if we can find some common ground.
Got it.
Okay, thank you.
Thank you. Thank you.
All right. Okay, who was up next? Is that you, Senator Boysko? Okay.
How are you all today?
Good.
All righty. So I have Senate Bill 1104 in front of you today. It is a bill to amend the state plan for Medicaid assistance services to include provisions for payment of medical assistance for violence prevention services. These are evidence-based, trauma-informed, culturally responsive preventative services provided to reduce incidences of violent injury, re-injury, trauma-related harms, and they promote trauma recovery, stabilization, and improved health outcomes. And they're predominantly delivered by violence prevention professionals who work in non-licensed healthcare providers in coordination with other licensed providers. The bill is supported by the Medical Society of Northern Virginia, the Health Alliance for Violence Intervention, the Virginia Community Violence Coalition, and the Virginia Hospital and Healthcare Associations. Today, as we discuss the fiscal impact, there is a $200,000 half general fund, half non-general fund FIS associated with this. In convening a work group, which is the direction we're going, DMAS said that the FIS would be $200,000 because they don't have the expertise within DMAS. I've spoken with several of the nonprofit groups that do this work daily, and they do have the expertise. They after the conversations that I've had with them, believe that they would be able, sitting on this work group, they believe that they would be able to provide the expertise that's currently not found in DMAS. And so I hope we can move forward with this effort.
I think, looking at it, it was suggested that maybe an amendment so that it would also report to this committee.
Sure, I think that's a reasonable thing.
Anybody want to make that amendment?
I'd be open to that.
Second. Motion properly supported that the report is generated will be reported to the Senate Finance Committee as well as the Education and Health. Get the House into it too. Want to get the House into it?
It's a good idea.
Okay.
Great.
They deserve something.
You got it. Thank you. Appreciate that.
Focus on that and forget to think about the bill.
Yeah, if we wanted to go through over there, maybe we should. Seem like there's-
Okay, great.
That's what. Okay, all those in favor say aye. Aye. That amendment? Okay. What's the pleasure on the bill?
As amended.
Motion properly supported that the bill be reported, or recommend reporting as amended. All those in favor signify by saying aye. Aye. Any opposed? Thank you.
Thank you so much for your time. Y'all have a good afternoon.
Senator Edwards.
Senate Bill 1269 is a recommendation of the Joint Commission on Healthcare. Senator Barker knows something about it. Basically what it does is to allow DARS, Department of Aging and Rehabilitative Services, to allow a limited number of auxiliary grants for people who would like to live in certain community settings. The bill is intended to enable older Virginians with moderate functional needs who are not able to find the auxiliary grant bed in assisted living facilities to receive the support they need. And Estella Obi-Tobitt of the Joint Commission on Healthcare, Health Policy Analyst, she can explain it better than I can.
Okay. Good afternoon. There and use the mic, that'd be great.
All right, thanks. All right. Thank you, Senator Edwards. So yes, my name's Estella B. Tabbitt. I'm an Associate Health Policy Analyst at the Joint Commission on Healthcare. As Senator Edwards said, the bill allows DARS to allow a limited number of auxiliary grant recipients to live in certain community settings. The bill is intended to enable older Virginians with moderate functional needs who aren't able to find an AG bed within an assisted living facility to receive and they're able to receive those supports at home. And just as a background, the AG is a state supplement to SSI's supplemental security income that provides maintenance to the care for aged, blind, and disabled adults residing in assisted living, adult foster care, and other supportive housing settings. So this legislation was a recommendation from the JCHC, and our research found the AG rate does not cover the typical cost of assisted living here in Virginia. And there's been a 41% decrease in facilities that participate in the AG program since 2010. And a DARS report also found that 114 ALFs have closed in the past 8 years, and approximately 19 have stopped taking AG residents. So this means that some Virginians who are otherwise eligible for the AG can't find a bed in assisted living, and they aren't able to access these funds for the necessary supports they need. And so funding community-based services could be more cost-effective and meet the needs of the AG population with lower functional needs. And other states do allow residents to reside in more community settings and modify rates based on their setting. And so the bill includes a delayed enactment to allow DARS to adequately plan and develop regulations for this new setting. And it also includes a cap of 200 recipients to manage costs and make sure the needs are adequately met before expanding.
Okay. Okay, Senator Edwards, as this was being reviewed, you have a budget amendment in for $140,000, and but that would not really cover the actual grant program. That might develop the program, perhaps, but would not pay the auxiliary grants for these up to 200 individuals, as it appears to me. There apparently was some thought that you all were giving to having a substitute where that DARS could develop the program.
Yes,
and then perhaps, but we would perhaps not deploy it or implement it until we come to grips with the funding side of it once the program was developed. Is that the thinking? I know.
Yeah, that was part of what we were looking at, sort of take for the people who would be in the community rather than in the assisted living facilities, to be able to have them sort of work at that out so they would really be able to provide us with information in terms of what specifically services would be provided and how they would identify the people and how they would make sure that these were the people that were most in need of that. But what we're also thinking of is looking at a further increase in the auxiliary grant rate to the assisted living facilities. So that I think there is a budget amendment in to go to $2,500, if I recall correctly, on per month on the auxiliary grant payments outside of Northern Virginia, and it's a little higher in Northern Virginia.
Yes.
And that would be able to get us from roughly 40% of what it costs right now to hopefully get closer to 60%, and to move forward in a way in which we're helping address the real need for this right now. So.
That's correct.
Okay.
And I'll add that the $140,000 is for one additional staff member at DARS to begin to develop this program, since there's a delayed enactment for January 1.
Okay.
And they expect to start to accept participants in this program in fall of 2024. So there won't be a fiscal impact for the program until that time.
Yeah. I would share that, in my opinion, the auxiliary grant program is extremely underfunded.
Yes.
We put,
Yes.
going back, I carried legislation, actually, it goes way back, when Jane Woods was secretary, I believe, when that we put additional requirements on the assisted living facilities, and we were supposed to come up with a significant amount of additional funding, and we never did. We've got small and modest amounts over time. So let's see, that would require a substitute. Do we need to structure that a little bit here before we go? What's the pleasure of the committee?
I think we could work on, we don't have to do it right now.
Okay.
But we could do sort of the structure that we would be asking DARS to look at, and then we could provide additional funding as it relates to the current system that's basically the assisted living facilities. So.
Okay. All right. Is there?
And I would hope that the Joint Commission would help us with crafting that.
Yeah. Right.
Absolutely.
Okay.
And the other issue that we need to be a little sensitive to is that auxiliary grant is not purely state funded, it's localities. So it's the cities and counties that support some of the people that are there. So.
Okay. What's the pleasure, committee? Conceptually, then, we want to recommend that the full committee deal with a bill that accomplishes that?
Right.
Okay. Is that your motion, then? Second?
Yes, second.
Okay.
More or less, anyway.
Motion properly supported that we conceptually recommend advancing the bill with some parameters on it, which are going to involve hopefully our efforts to increase the pot of money available for auxiliary grants, and then, as your bill suggests, developing how this would work. Okay. Any further discussion? Hearing none, all those in favor of conceptually advancing this signify by saying aye.
Aye.
Aye. Any opposed? All right.
Deeds, too.
Okay. Very good.
Deeds. I've got his
He's
proxy.
got proxy. So we got a concept flow to you. I know you can't draft it from that, but we'll work with you on that. Exactly. Thank you.
Thank you.
Thank you. Okay. All right, Mike, I guess we get you restarted again here. I apologize for jumping you around. Oh, there's the ones. Okay.
So I'll just continue to be the entertainment in between.
Hey, just talk numbers. Yeah.
All right, so I think kind of did the quick overview. So like I mentioned before, behavioral health, of course, is the largest spending item within HHR and the governor's proposed budget. And I'll go into a little bit more detail on the next slide to talk about the comprehensive crisis services system. $58 million is what the governor proposed. There's $20 million for the hospital-based psychiatric emergency alternatives. This would fund an additional 3 to 6 sites. You may recall a few years ago, the General Assembly had funded some pilot projects. One of them was at Carillion, and this is basically a psychiatric ER, and something that I think if you talk to them, they would say has been very helpful, especially during COVID. It helped them a lot. So this would sort of expand that to additional health systems. Mobile crisis units, $20 million is proposed. There's currently about 32 teams, and the goal is to help try to get closer to 70 teams, which is kind of what they have developed as the standard would be statewide to basically be able to respond effectively. School-based mental health pilots. So $15 million. If you remember last year, the General Assembly approved $2.5 million to start this. So they're already working with 6 school districts. So this is really kind of developing a program that kind of takes a deeper dive into a deeper step into more intensive services of behavioral health in the schools beyond just what a school counselor would offer. So they've started that with 6 school districts, and this proposal, the idea is to increase it to about 33 school divisions with $15 million. There's also $9 million to do salary adjustments for facility housekeeping and food service staff. If you remember last year, of course, the initiative was related to direct care staff. So this year, this is more focused on really the lowest income individuals within the facilities. There's also $8 million for housing for individuals with serious mental illness. So this is really actually a focus on group mental health homes, not permanent supportive housing. So this would fund about 100 placements. And then lastly, there's $1 million for the off-duty officer program to assist with temporary detention orders. They currently have agreements. This is something they've used internally with some funds, but this is $1 million to help sustain it and expand it some more. They currently have agreements with 11 departments. So essentially what the agreements say is that, just like off-duty officers do with lots of things, they cover events and things like that, and they get paid for that. And so this basically does the same thing, that they could either wait in the ER with the individual while they're off duty, and so it doesn't require an on-duty officer to do anything, or they can transport them somewhere. Just to note in the other areas, kind of in the overall package, the behavioral health workforce, I'll talk about the loan repayment programs in a minute. Then there's $9 million at SHEV for mental health services for K-12 and higher ed. And then on the compensation board, there's a separate mental health transportation pilot for $4.1 million. And that's really tied to actually supporting sheriffs, but more from the on-duty perspective, giving them additional supports to the compensation board to handle TDOs. And then to note, too, there's throughout the budget, there's also about almost $15 million appropriated for the fentanyl response, and that's from the opioid settlement funds, which we'll hear a little bit more about next Monday. So moving to slide 4. So this is just a quick recap on the crisis system. Do you want me to pause, Mr. Chairman?
Yeah, that's a good break point,
Okay.
I believe. Senator Hashmi's in here. If we could get her up here.
Good afternoon. Thank you, Mr. Chair. This is SB 802, and it's my understanding that there is no fiscal impact. I believe that's what we've received from staff, that there would be no, or it's indeterminate, rather, in terms of fiscal impact, but... Negative?
Negative.
Oh, okay.
Even better.
It's
for you.
even better. This is the counseling compact bill that we had introduced last year, and we are attempting it once again. It would authorize Virginia to join the Interstate Counseling Compact. Right now, we've got 17 states that have already gone ahead last year to join the Interstate Compact. Virginia would be among 10 more that are considering joining the compact this year, putting us at 27 states, or the majority of the states in the country, that would be part of an interstate counseling compact. This really is designed to help us address our mental health crisis. It would allow for telehealth services from licensed professionals to provide counseling services. It would also allow Virginia licensed counselors to provide those services outside of Virginia as well. This is a bill that is heavily supported by the Department of Defense. They have been actively engaged in trying to expand these services, especially for military families that move from state to state, and it would address a lot of the critical needs that we have in counseling and mental health services in the Commonwealth.
Okay. I think this is fairly simple, but yet important. So, and the key for us here is examining the fiscal impact, and there is none, so it should be an easy one for us. What's the pleasure of the committee?
Indeterminate.
Indeterminate sometimes is not good.
Yeah, but this is indeterminate. Negative.
Okay. Oh, that's good.
That is good.
That is good. Okay. What's the pleasure of the committee?
Move to recommend reporting.
Okay. Motion properly supported to recommend reporting. Further discussion? Hearing none. All those in favor signify by saying aye.
Aye.
Any opposed? All right. Thank you, Senator Hoshman.
Chair.
Most of those compact, the ones that are agreed, where are they dispersed? All over the country, or mostly on the East Coast, where you know?
They're all over the country.
Okay. Okay.
Certainly the states around us have already.
Around us, to the south too?
Close. North Carolina's got it up this year, I believe. North Carolina has it up this year.
Oh, good. Okay. Okay. Some.
Virginia,
Uh huh.
Maryland, Kentucky.
Okay. Thank you. As long as California technically, that's a negative on the other side.
I know.
Okay,
All
Mike?
right, Mr. Chairman. So, and at this point, we're just waiting for Senator Donovan, which I've sent her a message, and Senator Mason.
Okay, all right.
So this just slide is just for your information to summarize the crisis system. You can see in Chapter 2 last year, there were basically 6 additional crisis receiving centers and a crisis stabilization unit that were authorized. And so it just kind of totals it so that you can see. And then, of course, in what's proposed in Senate Bill 800 is basically to enhance pretty much a lot of the crisis stabilization units with additional funds, to establish 3 new ones. It also creates 2 youth crisis stabilization units, 6 more crisis receiving centers, 5 more youth crisis receiving centers, and a crisis therapeutic home in Region 5. So you can see that summarizes the funding at the bottom. Current funding of about $54.6 million in FY23. FY24 is $47 million. So the additional proposed funding of $57.5 million in SB 800 would bring it to just over $100 million in fiscal year 24. Just the note in the next slide 5, just the other DBHS amendments. There's funding for 3 additional forensic evaluators, one for Eastern State, Western State, and Central State. And this basically helps to kind of keep, providing additional treatment services and evaluating individuals to get them to restored competency so they can actually be moved out of the facilities. There's funding to support the waiver management system, 2 cybersecurity positions to support the department's IT, 2 positions to fund waiver administration for the developmental disability waivers, and then a little bit of a small amount of money to fund forensic data tracking and analysis. So the next slide, 6. So these are the healthcare workforce amendments that Dr. Green kind of went through kind of thoroughly. I'll just note for them that the Nurse Preceptor Incentive Program, there's $500,000 general fund in the base, so their proposal is to add $10 million to that. The Behavioral Health Loan Repayment Program, which is a newer program too, has $1.6 million at the base. So the additional $2.5 million would put that to just over $4 million. And then the $1 million for just nursing scholarships and local in the repayment program, loan repayment programs, that kind of doubles it. It has $1 million now, so that's an additional $1 million. So just to note, he already kind of covered these other things, the state match for drinking water, the salary adjustment for the Office of the Chief Medical Examiner. I know based on your questions, this was a partial funding of their actual request the process. So we do have the information to look at, if that's something the subcommittee went to look at doing any more.
Mr. Chair.
Senator Barker?
Yeah. If I might jump in, one of the things on the nursing education situation is that we need to be able to get faculty, because right now there are far more applicants for trying to get into the nursing programs than there are slots, and the reason that they're not able to do anything to take more people in many of the higher education institutions is because they don't have enough faculty, and they don't have enough faculty because the nursing the nurses that would be likely to consider being faculty there, if they're working at a local hospital, they're making far more than what we pay them there. And so we need to, that's where we really can need, and actually we would probably get far more new graduates for every dollar we put in if we do it on that rather than some of these other things. So we may need to sort of shuffle that around when we're looking at how we get everything done. There have been some increases at a couple of the schools recently, both Radford and Longwood had done that, and some of the local community colleges have also been pretty creative in terms of getting staff in there.
Yeah, I know that's a problem, Senator Barker. I was wondering if we were to target young nurses that are taking time out from full-time duties to be moms, that they could do it part-time or something like that if we had adequate child care. Adequate child care is always an issue, isn't it?
Always.
Right. Yeah. It is a problem. Yeah.
So we need to, sort of.
Right.
The problem right now is not that there aren't people who are applying for the nursing programs there.
Right.
It's that they don't have enough staff to be able to take all of the people who want to be nurses.
Okay. Good, Mike.
And then you can see some of the smaller amendments that Dr. Green already covered. So moving on to the Department of Medical Assistance Services, of course, the Medicaid forecast, again, savings from the public health emergency and the enhanced federal match. The healthcare fund, which is state match for Medicaid, you can see it's negative in the first year, then positive in the second year. It's a lot more variable in recent years because the managed care companies and their repayments to the state go into that fund, and that's offsets Medicaid expenditures as well. Then the extension of the federal public health emergency. So this is where they were adding additional quarters that they were assuming that were going to occur. So you can see the additional savings there. And this is where in December when Congress passed their appropriations bill to end the fiscal year that they basically proposed to decouple the enhanced federal match from the public health emergency. So for Medicaid purposes, on April 1st, that's when it ends, and they created a phase down of FMAP that will require us to put a little bit of money back, about $30 million in the first year, but we'll save $130 million the second year. So it nets to about $100 million in savings. And that will be pretty much the end of the enhanced federal match. You can see, again, the Children's Health Insurance Programs, they also receive a part of the enhanced FMAP, so you can see the savings there, about $22 million total. Medical costs for involuntary mental commitments is just slightly down. I already mentioned previously the personal care rate increase of 5%, the 500 DD waiver slots, that would bring the total in the second year to 1,100 because there's 600 funded in Chapter 2. Right. There's $2.3 million for the Cover Virginia Call Center settlement. This is kind of an issue that they had with their new vendor for their call center that they didn't really pay them for 18 months until they resolved it, and so they're reconciling the payments back to it. And then there's $1.7 million for the administrative costs to begin the reprocurement of the Medicaid managed care contracts, which as I've mentioned to you all before, are pretty much the largest contracts that the state engages in. There's an increase of 12.5% for the early intervention services. If you remember, this was a temporary increase that last year you all agreed to extend them all permanently, but this somehow kind of fell off the radar and was left out. So this basically fixes that oversight. And then there's an additional 20 psychiatric residency slots, which you all remember last year you all had authorized some additional ones. So this is 20 more. And then some.
Do you know how many residency slots have been filled out of these 20?
Mr. Chairman, Senator Barker, I'll have to double check, but I'll find out. Okay. Now moving on to the Department of Social Services. You'll see that there's, TANF is typically a non-general fund except for the one piece, which is the TANF Unemployed Parent Program. So this is the two-parent program. Basically, it is doubled in size, so it's a very small program, but their projections require about $15 million over the biennium. It will start to go back down. It really has to do with the fact that during the health emergency that they've suspended work participation requirements, and not to get in the weeds, but it sort of has a temporary effect of like more people can enroll, but once the requirements come back in, they kind of come back off. So it's then there's $8.3 million for the Office of the State Inspector General had conducted a CPS review a few years ago. So this is implementing this. This is sort of just a drop in the bucket because it funds about less than 70 positions. The State Inspector General said that I think that the entire system needed somewhere in the magnitude of probably 800 plus. But this sort of kind of puts some money toward that. There's $6.1 million for a SNAP repayment to the federal government. This is basically their vendor basically put it in a day early, and so it was. So the feds want it to be repaid back, but DSS is still working with them to figure out. Well, maybe it could be a little bit nicer and kind of give us a pass on it, but we'll see what happens with that one. There's $3.8 million for local social services shared site technology. So this just deals with some of the local departments that don't really utilize the more secure state systems. So this kind of moves them to an environment where they can. $2.3 million for foster care and adoption assistance cost of living increases. So as you know, the Appropriation Act requires that the year following a state employee pay raise, that same raise is applied to the adoption and foster care payments as well. Then there's about $900,000 to expand the number of kinship navigator programs from 6 to 12. and then conversion of a couple positions from full-time to part-time to full-time in SNAP. And the child welfare forecast you can see at the bottom is a negative of almost 20 million. That's also, of course, the enhanced FMAP for Medicaid actually applies to the Title 40 federal program that funds those as well. So moving on to the disability service agencies, these are a lot of smaller requests. So you can see in Department of Blind and Vision Impaired, it's basically some additional money for their employment services, as well as in DARS as well for vocational rehab services. And then you can see there's an increase in the personal care services that DARS provides to people with disabilities, but that just is to match the Medicaid increase that they had proposed in Medicaid. And then some smaller items that you can see there as well. Other Health and Human Resources amendments here in slide 10, the Children's Services Act, the only actions there, there's a $6.9 million reduction in the first year, 23, due to based on their estimated expenditures. There's a $29.2 million reversion of cash from fiscal year 22. So this is primarily down for the private day placements for special education, which y'all have heard about for years now, is down about 300 kids. And so that's the more expensive population in CSA, so that translates into this. It's not to say that it won't go back up, but that kind of temporary reduction passes through to savings in CSA. And the Secretary of Health and Human Resources Office, there's kind of three different, contractors or studies. One is to assist with implementation of the behavioral health transformation. One is to look at developing a strategic plan for the healthcare workforce. And the last one is to study coordination of certain behavioral health services for veterans. And Department of Health Professions, just as typical, they get adjustments just for whatever their workloads are with the regulatory boards. The Opioid Abatement Authority was established as an agency, even though it is independent. It is sort of, and the budget is an agency that shows up under the HHR Secretariat for just its non-general fund appropriation. So this is sort of the initial. They received an administrative appropriation for the current year. And then lastly, we already discussed
some settlements that provide good-sized funds. So.
Yes, and Mr. Chairman, Senator Barker, next Monday, the authority will provide a brief kind of overview, because there are two bills related to the opioid stuff that you'll be hearing next week as well. And then lastly, we already discussed earlier with the Health Department about Part 4, the restrictions and spending related to abortion services. So,
Mr. Chair.
Senator Barker.
It looks like the rest of everything is pretty much the long wish list
yes.
from 40 different people. So, but I talked with Donovan, Senator Donovan today, and on the two bills that she has in that are listed here.
Go ahead. Well, I think she has three. There's one that I think might be simple. Is that the one you're speaking to, or?
Well, actually, I was talking. One of them doesn't have any fiscal impact.
Right.
And but the second one, which we did talk about it earlier today, was the autopsy one, and that is for people who are in custody in the criminal justice system. And what she indicated was that they have had some individuals who died, and there was no autopsy done, and then later when somebody did an investigation, and I think the AG's office was part of that, they had real questions about some of it. So what this would do is set it up so that there's a decision tree that would indicate when you do have an autopsy done, and so the medical examiners would have to do that. But she said that they're estimating it would be only 20 additional autopsies per year, so it's not a huge.
That's Senate Bill 1232, I guess you're speaking to, that's on the docket. Is that the one?
It is 1276.
Oh, 1276.
1276, and it says it's minimal on fiscal impact, but.
Okay. There is a separate one. The other one is very similar to that.
Yeah, but the other one basically says no fiscal impact, and it is just an the other one is just investigations.
Well,
it's not autopsies.
Right. So, well, I was looking at 1232 initially, and it seems like we could go ahead and recommend that one.
Yeah, I think
without her presence here. Y'all okay with that?
Yeah.
All right. Let's look. Senate Bill 1232, dealing with death investigations, no fiscal impact.
Right.
It's reported to us unanimously from Education and Health. Well, the fiscal impact would be what, our health commissioner was talking about. We got to have medical examiners there.
No. This is just investigations.
I know,
And
but,
investigations are,
right, what I'm saying is if you don't have anybody to investigate, it's an indirect cost, is what I'm saying. If he doesn't have enough people to do the investigations, he can't do the investigation.
Obviously, there are shortages of medical examiners.
Right. This bill doesn't incur any additional
Yeah. No,
cost.
and this doesn't-
But what I'm
and
saying
that
is
just
he
doesn't-
already
yeah.
doesn't have enough people to do what he's.
But it's
what he-
the other one that is the one that has the autopsies.
Right, okay.
So that's the one.
Okay, all right, on 1232, is there a motion to recommend reporting it?
Move to recommend reporting. So.
Senate Bill 1232, death investigations, okay. Okay, any further discussion? Hearing none, all those in favor say aye.
Aye.
Okay, any opposed? All right, we'll recommend reporting that one. Then the one you were speaking to directly then on the autopsies is 1276.
Right.
And you're suggesting that that's a minimal cost and,
Right.
and
Yeah.
we'll do it? Okay. What's the pleasure on that one then?
Make a motion to recommend reporting of 1276.
Okay. And seconded. Any further discussion on that? Hearing none. All those in favor signify by saying aye.
Aye.
Any opposed? All right, that one. And,
Yeah, we're down to two, but I'm the problem on those because I gave my proxy to Monty Mason.
okay. Well, his bill actually is one that, yeah. Y'all want him to speak to it later? It seems pretty simple.
We could just go back, take it by for the day.
Okay.
And,
Okay, and then the other one for Senator Dunn would take it back for the day?
Yeah.
Okay, without objection, we'll do that. It was, Senate Bill 987 was indeterminate. There's probably going to be a minimal, but some impact.
And the one that's says indeterminate on 998, but also says significant general fund impact, so that was.
So he's got to come back.
Need to take a little closer look at.
Okay. All right, without objection, Senate Bill 987, 998, and then Senator Donovan's other bill, which.
Are those only, we already
Acted
did-
on her too. Yeah.
You only had two?
Yes.
I thought you had three. Okay, good.
All right.
That we'll come back at that next week.
Yeah.
So, Mr. Chairman, that concludes the bills. It also concludes my presentation, unless you want me
Okay.
to go line by line through the 175 amendments of HHR. But
Only the first 173. So we won't like those last two, so, yeah.
We'll have to have a coffee pot when we do that. All right. All right, with there's no
Bring your
further.
popcorn, so.
Yeah, something like that. All right, thank everyone for your attendance today and attention to these matters, and the committee will rise.
Yeah.